Our next speakers come from US. He's a biomedical engineer and is director of the telehealth initiative for MedStar Institute. And he's going to speak about moving telemedicine from bench to bedside, success, failures, and lessons learned. Dave, you have the...
So thank you again to all the organizers. This is an amazing event. I've sprinkled into my presentation some photos of your amazing country because I spent 3 days in Calabria and fell in love. So I'm the unofficial tourist ambassador for the south of Italy. So thank you. So again, great meeting. It's excellent to be here. So I'm from Washington. How many folks, so there's 2 Washingtons in the United States. How many folks have been to the Seattle, Washington? Okay, well that's not my Washington, unfortunately. This is my Washington, so I'll apologize and leave it at that. So this is Washington, right? This is my daily commute. So reflecting on why I'm so happy to be here, this was where I was 2 days ago. So this is the sort of road I would prefer to be on. This was in Civita. Okay, so my background, I'm a biomedical engineer by training. I spent the first 15 years or so of my career, and this will be a slightly different talk, I think, from the rest of the session, but I'm hopeful that the perspective I'm going to share with the group will really sort of take the conversation. I think it dovetails great with Trevor. We'll take this conversation into a good direction for us, setting forth an agenda after the meeting. So this is the large national rehab hospital in Washington, D.C., 141 beds, about 40 outpatient clinics. The first grant I worked on in telerehab was 1999. So this was no fast internet. This was dial-up modems. This was me in 1999. And this was the world, right? This was a video phone that plugged into a wall, a television, a typewriter, full head of hair. And that was your inbox. That was literally your inbox. And most of us were around. And this was how I sort of spent the first 15 years of my career. Most of my time and effort in those early years were spent in speech therapy, so tele-SLP. That's where I met Deb and Trevor and the amazing folks from Queensland and the great work they've done. That's my colleague Amy Georgiadis. I saw her name referenced in a publication yesterday. And it's having been out of rehab for the last 8 or 9 years, which I'll get into in a minute, it's amazing to be here and hearing questions from people who I've cited literature on for years. So you guys are the responsibility, I mean, these are the legends of the field of telerehab in this room. This is an amazing event, so kudos to you. So some of the work we did, again, a lot of, as Trevor said, pilots, validity, some assessment projects, impactful research, but at a fairly small scale. I was one of the original authors of the American Telemedicine Telerehab Guidelines. I worked with the American Speech Hearing Association as their technical expert on their guidelines. Later in my career, I did some work in tele-OT with home-based constraint-induced therapy. We did some rehabilitation robotics. So sort of dabbled in a lot of things really as a technologist and not a pure researcher. So I hadn't updated this graph since I moved out of rehabilitation, really before the inflection point. I was astounded when I did not a full scientific, this isn't a meta-analysis, but telerehab, all fields on PubMed. I mean, look at that explosion. And those last 2 years don't even include 2/3 of 2019. So the field is taking off. I think we're in a wonderful place. But certainly, as Trevor said, more research and work is still needed. I heard things yesterday that I heard 7, 10, 12, 15 years ago. I think where we are, it's an exciting time. So where do we go from here is really what I want to talk about. Trevor gave an amazing presentation about the technology evolution. High-speed internet access everywhere. Again, I was using copper lines, dial-up phone modems. I don't think anyone in this room right now, obviously there's pockets where connectivity is not great. I found many of them in Italy. But for the most part, when you can get internet, video is now essentially free. It's a commodity. It's not hard to do. There's more power in your smartphone than was in the mainframe computer in NASA that sent the first lunar lander up. But our patients expect information everywhere, right? They expect to be able to order anything from your phone immediately. A funny story about the power of technology, and I'll poke a little fun at myself. So this was my rental car, okay, a Fiat 500. Great car, right? Maybe. I've not driven a manual transmission in quite some time. It's a 6-speed, so I pick up my car in La Mesa and I drive out to the coast before I do some travels, make a wrong turn, of course. My phone's not active yet, so I don't have data. Fortunately, I had downloaded Google Translate. Dead-end street. Oh, reverse is top left. I didn't know you had to lift the little lever to get it in. So now my car can't go in reverse and I'm in a dead-end street. This is interesting. So Google Translate, I hold the camera up to the manual of the book, and it does this translation to point out to me where the little ring is on the stick shift. Like, that's totally unrelated to telehealth, but I thought this was the coolest thing in the world. So for all of you world travelers, download Google Translate, and I should buy another stick. Okay. But how far have we come? This was a lot of the conversations. These were direct quotes I heard yesterday. The doctors won't use it. Can patients set up equipment in the home? How are we going to train our clinicians? Who's going to pay for this after the grant? These are still issues that we're facing in telehealth, so how do we move forward? Okay, so to pivot a little bit to the perspective I want to bring now. So I spent most of my career operating within one hospital. An amazing hospital, did tremendous work for rehabilitation. But the reality is that that hospital exists within a larger healthcare system of 10 hospitals. This is a $6 billion healthcare system. We're the largest provider in Washington and Baltimore. We have many big hospitals. That's probably outdated, probably close to 5 million outpatients a year, so we're a huge footprint. I was given the opportunity to move from tele-rehab to telehealth and to try to solve problems at the system level. So for the last 7, 8 years of my career, that's what I've been doing, and that's the perspective I want to share with you in the next 10 minutes or so. What's very impressive about our system is we don't just have big hospitals, we have small outpatient centers and walk-in urgent care clinics, and we have a home doctor program that sends doctors to the home, and a nursing program that sends nurses and PTs and OTs and speech therapists to the home. So our footprint is huge. What this lets me to do, I'm incredibly fortunate. The projects I do in telehealth they're every conceivable type of telehealth, from home-based to hospital-based to visits on your smartphone. This is really the world of healthcare in one small geography of Washington, D.C. We span 3 different states. We have issues with licensure. I'm sure a lot of you folks have, if you don't have it in the countries where you're from, in the United States, licensure is a huge issue. A physiotherapist in one state can't treat a patient in another state. So we live these pain points every day in my life. So my job is to do this, to take technology back to the patient. And that's really what I'm driven by. That's what all of you are driven by, all of us here. This is where healthcare started, and this is where we want to take it. It's using technology, but it's doing the healthcare the way it's meant to be done. I'll show you a real quick video, I think. Can you hit play in the back? So this is our health system.
We have come a long way. If Hippocrates, the father of Western medicine, could see us now, we would blow his mind. Stat. All the amazing advancements in medicine. Great things like tomography and proton therapy. All the implanting, the transplanting, the lasering, and the minimally invasiving. And while science has become better and better at treating people, we can't ever forget the importance of how we simply treat people. At MedStar Health, we believe it doesn't take a brain surgeon to get you might want us to come to you after surgery, or that the best way to talk to a doctor isn't always in person. And when the contractions are getting, real close, it's good to have a hospital that's, real close. And never forgetting that inside every human body lives a human being. The best of our minds, the best of our hearts. MedStar Health. It's how we treat people. We have...
It's good. We don't need to see it again. What amazed us there, that was the first, we spend a lot of money on advertising, a lot. That commercial's running nonstop on television. It's the first time that our health system said, we do telehealth, right? We're not in a rural area. Traditionally, MedStar's done telehealth, it's been researched. This was the first time, right in the middle of that commercial, there's somebody seeing a doctor on his phone, and that was transformational for us. So moving information, not people, that's what we're driven by. I'm going to speed through some of this to really get to the meat of it, because I do want to leave some time for questions. So our health system, we formed an official center. There's 8 members of the team. We have a vice president as our lead. We have a medical director, does all of our medical oversight. The way we operate, we sort of go out, people come to us with ideas, we have to implement them, and then we have to operate them, help them sustain them. This is a lot of times the email I get. I want to do telehealth. And I have to say, oh, okay, great, who are you? So these are sort of the questions I've gone through, and somebody touched on some of this yesterday. I'm blanking on who the provider was, or the speaker. The first question I really have to ask them is, what do you really want to do when you see a patient remotely, right? And this cuts to the heart of everything we do in telerehab. If you're a neuropsychologist, it might just be, conversational. If you're a physiotherapist, you might need some sensors. A speech therapist, I need to see you, hear you, and put up something for stimulus that you can respond to. So for a lot of what we're doing in sort of traditional healthcare, it is seeing and hearing, but it's a lot of information we have to move. And then we get into the question of, is this a scheduled visit? Is it an on-demand visit? Where's the patient? Are they at home? Are they in a school? Are they in a different state from you? Are you licensed? Let's not talk about how do you get paid. We'll talk about that later. That's harder. So that's sort of what we do. These are the types of encounters that we offer in our health system. So e-visits are what we call the sort of direct-to-consumer. So that's what that gentleman in the video used. I have an app on my phone. I can get a video 24 hours a day, 7 days a week. I can connect to a doctor or a nurse practitioner. And these are for urgent care, very quick visits of, I think I'm sick. Should I go to the hospital? Should I call my doctor? E-consults, telestroke, teleneurology, things that are more on demand from one provider to another provider. E-clinics we do where we connect all of our locations, and that's where our providers don't have to travel. You drive to your local clinic and you'll do a scheduled visit with a provider in another location. And then e-health is an area we're pushing into pretty hard. Trevor touched on this a little bit with his example in the pediatrics program. But giving patients technology at home where we can sort of surveil and monitor them. We have a big program there right now in palliative medicine, which I'll speak to in 1 second. So we see about 2,400 individual patients a month. This is good numbers, but as far as for the size of our system, it's not great. We're growing quickly. We have one service, and I'll actually just put this one up. So we have a doctor, 7 days a week, emergency physician who works in an office. So if you've ever been in an emergency room, you know they're kind of chaotic. So the life of an emergency physician is not, they love what they do, but they are exhausted. So to say to an emergency physician, hey, next Monday you get to sit in a quiet office by yourself for 12 hours, they're very happy. So what we've done for that one shifted provider every day, they sit there and they take video triage requests. So across a couple of our emergency rooms, when a patient comes in, the nurse can bring up the doctor right on screen and get tests started for the patient quickly. We took that same physician and we push calls into him or her from our walk-in clinics. So if you go into a walk-in clinic and they say, well, I'm not liking your EKG, I think you should go to an emergency department. Let's confirm with the ED physician before you go there, Or sometimes you walk in and they say, I need a second opinion, so they talk to the ED doctor. We've also recently given the capability for our nurses who go out and visit patients at home. So if you have a patient who's decompensating and you're a nurse and you don't know what to do, you can also spin up access to this. So this is a specialist who's available to a pool of people. And our goal is really to scale this to a lot of different locations. That's sort of the on-demand provider consultation model. E-visit, I talked about that direct-to-consumer world. We are doing a decent amount of visits, but not a lot. As you can imagine, the more commercials you run and the more ads you send out in the mail, the more people will use it. And that's sort of how that works. More importantly, we're using that same platform for people to do scheduled visits. So we're live in a number of our surgical practices for follow-up visits. After a surgery, you have to come back to see a doctor. A lot of times we can just do that by video because it's just a video check-in. So we can do that as well. That's our e-visit platform. For our palliative program with home monitoring, we send patients home with a tablet loaded with a platform, the company called HRS. They're an American company out of New Jersey. This gives the patient, it monitors their vitals, so they have a blood pressure cuff, they have a scale, they might have a spirometer if it's needed. It gives them medication lists. It asks them questions every day, a couple times a day. How are you feeling? Did you sleep? Could do typically a depression inventory. Can also do messaging and video conferencing. So for the palliative team, this is really how they video into the patients. We have patients who will take this tablet to their doctor's appointment and have the social worker video in to meet with the doctor to help manage medications. So it's a pretty impactful program. Anyone recognize this? It's close by. Santa Severina. So a strong foundation is essential. So I want to quickly touch on these 5 key things, because this is really, I think, the take home of going from research and put it in practice. We've talked a lot about workflow and adoption. But traditional care is not virtual care. A lot of the things we found when we try to put these things in healthcare, how do you schedule a patient? How do you room a patient? When a patient checks in by video, a lot of times people might not know about them. So when you pick a platform to put in place, you have to think about these things. There's no easy way to fill out paper. So we have to have all of these forms now are digitized, and our legal department has to confirm all of that, which is fun. And there's a complete reliance on technology, right? If someone's running late in an office, somebody else can keep them comfortable. If someone's running late virtually, you need a way to notify that patient. There's no way to actually get in front of someone when they're not in the same space as you. For workforce, we talked a lot about this, that top one, right? I don't think any of your programs started because someone said, I didn't want to do telerehab. But once you put it in place, suddenly they don't want to do telerehab. That's a problem. So very early, we get in front of our users, our people who work at the desks in the office, who do billing, and we ask them, you know, what do you really need to do? We shadow them. We put someone in their office for 2 or 3 days at a time and really understand all of their workflow. We do the same thing with patients. We understand how the patients are used to seeing a doctor to make sure that what we're giving them meets their expectations. And we celebrate success and failure, right? If we stand up a new practice and they've done 20 scheduled virtual visits in the first week, we give them a plaque. Doesn't mean anything to us. It means a lot to them, right? Celebrate the champions and rising tide within your hospitals and within your clinics. People will see people be rewarded for success, and they will want to get on board. So if you have a great patient story, circulate that far and wide. Let everybody know what you're doing, and learn from your failures. Technology, pilots are hard. I have a saying, I say pilots are like zombies, they never die. So we have to be careful of, we get a lot of people who say, hey, I have a new gadget I want to use. It's hard to do pilots in a big system like ours. There's a value to them, but we have to be very careful. We do a lot of integration. So now the same scheduling system that we use to schedule a clinic visit, there's an option there to schedule a virtual visit. And that kicks off a whole series of automated processes in the background. But we can't make things dissimilar from the normal workflow, or users will walk away. So that's challenging as well. Data, I was thinking about how my life is different now from when I was doing research. One way it's not different at all is that data is hugely important. But we're not doing statistical analyses of a randomized control trial. Every day we're monitoring our platforms to see if there's issues, to see how long patients are waiting, to see if people are having problems during a scheduling session or a customer satisfaction survey doesn't get sent out. So we have to collect all that data for ongoing improvement, and then identify opportunities to really improve. Look at clinical adoption, look at training and satisfaction. Lastly, I think finance, this is big. Return on investment in telehealth is difficult. Traditionally, it's hard. Reimbursement's not great. I don't know how much you pay attention to what's going on in the US right now, but we're not good at healthcare. We're really not. We're good at spending money on healthcare. We're not good at delivering good healthcare. That's 100% honest in my estimation. But one thing we've started to do is shift our thinking from volume to value. So within our health system, we're able to say to a hospital, you know what, you won't get paid for that visit, But if that patient comes back to your hospital, you're going to get a penalty. So why don't we give away the virtual visit to keep the patient at home? Because if they come back, you will be penalized. We also have new models in the US which are exciting, where if you can actually maintain your costs, you get a bonus. So we're trying to find this alternate valuation of digital engagement with patients so that we can really keep things moving. And that's true for, you know, psychology, neuropsychology, physiatry, any specialty. So that's not excluding tele-rehab. Trevor had a similar slide here. This is sort of how all of our healthcare, and this isn't just the US, this is really the world. We're moving from care that is, I see you in my office and I forget about you, to I care about you all the time. One siloed provider practicing alone, now team-based care. I mean, rehabilitation, it has been team-based care forever, but we see this everywhere now. From healthcare that's reactive to proactive, certainly with some monitoring, and things that are really transactional to relational. Our focus is really about, you know, healthcare in rehabilitation has always been relational, right? If you have a stroke, you're part of a care team and you get to know them intimately and they care about you forever. How many of you see your general doctor more than once a year, right? You don't really have a relationship. But if you can build a relationship with the health system in which that doctor practices, and every doctor in that system knows you, whether or not you need you need a knee replacement, or God forbid you have cancer, or you have another traumatic event, all of that care is seamlessly folded up into this relationship that you have with your provider. So that's really the vision we're having. And I'll end with this again. We have to do technology. There's no way not to have technology in the delivery of remote care. But at the end of the day, this is really what healthcare is about. So I'll leave that up there. And then shameless plug again for my travels in Italy.
Thank you, David. You open a lot of interesting issues that go beyond the US borders, I think. And I open for 2 questions the floor. Is there any question? If not, I have one, and it's the following. In UK, for example, the telehealth is a choice. You can choose either to have a GP or to have telehealth with the Babylon system. Yeah. So my question is, when you are asking whether the patient wants to have, well, if they say no, will you provide them rehabilitation in any case? Will you have a physiotherapist enough to go home and see them? Will you support the patients in any case? Because sometimes, and I think there is a big ethical question here that didn't really come out, and it is, what if patients don't want, and it's the same for you in Australia, I think. We are proposing it, but what if patients prefer to have the human contact?
There we go. No, that's certainly a huge issue for us. All the programs we do now are opt-in. You know, there are plenty of patients who, they might have the app on their phone, but they won't use it. We're trying to have our doctors and our nurses and our clinicians, therapists, be our self-promoters. We'd like them to use it. The app that we use for urgent care visits, as an employee, it's actually free for me. So if I go to an emergency room, it costs me, I don't know, $250. If I go to an urgent care clinic, it costs me $75. If I use the app, it's free. So that's one good way that we're trying to sort of, you know, eat our own meal as providers to try to get people to use it more. But certainly there are times, and we're large enough where we do have that option to say, you know, a clinic option is available for you, but if you'd like something now, virtual would be another option. But that's a great question.
I'm sorry, I have an observation. Hi. As I mentioned, I work for the Veteran Administration in New York, right? So, and it's amazing me the fact that also within the same place, we work at the same doing the same thing.
Yes.
You know, the Veteran Administration is one of the largest telehealth organizations in the United States. We do all you do, and yet we don't talk with each other. We don't even have the problem with the license, because I can work anywhere in the United States. And it is, I think, it's just a waste of resources that we could just put together and build a better place with telehealth. So
we call it the Crotone Pact. Okay, so this is the US Crotone Pact, and you have a coffee together. So that.
No, that is a great point. I mean, and the Veterans Administration has done amazing work, and they're not hindered by a lot of the same regulations that private has. So it's a good point.
Okay, thank you. I have just a short comment and a question on your explanation. What happened, for example, if the patient entered into the telerehabilitation program and changed his mind?
That's a fair point. That's a great point. I'd love to defer to everyone else in the room to see their answers, but no, that is a very it is a good point. I mean, we're going to reach this inflection point where for some reason, and ultimately we say to our providers, right, the decision is yours. If you think a patient's, first of all, if you think a patient's not appropriate, you're not going to offer it, right? If it's a patient for whom they won't be comfortable, they're not safe on their own, or for some reason you need to have somebody with hands on them, your option might be, well, why don't you come to a clinic and you can see a nurse or a medical assistant and I'll be remote, or failing that, we'll bring you to me if that's an option. For us, fortunately, what's nice about the way that we're so spread out by geography, we're close enough that patients can get to us. It's not easy, but I know there's plenty of people here, especially internationally, where distance it's an immovable barrier. There's no other alternative. So,
I'm sorry. Can I also add that once the patient try, our experience is that they don't want anything else. Yeah. They don't want to come back to us in person. They just want to continue using telehealth. Yeah, so it's just a matter of getting them.
Yeah, I don't think most people would prefer to sit in traffic once they haven't had to, but.
The very, very last question between now and the coffee. So it's you. Yeah.
One of the interesting things in the UK is a lot of people will not go and see their family doctor because they don't want to take the time of the family doctor. And although it's been quite difficult to get patients to ring a doctor or for the doctor to ring them, it's slowly evolving that both sides feel that this is a better way rather than leaving it for 2 years to see anybody. But it's extraordinarily slow.
It is slow adoption for sure. I can give you one number. One of our post-op programs, we looked at, I don't know, their first 40 or 45 encounters, and they were on average about 40% shorter than an in-person encounter. Yeah. And I think they're more brief on the phone. Satisfaction was fine. Patients didn't feel like they got less time with the doctor. But the providers, once we showed them those numbers, they were very happy. And we also have providers who are at the point where we're saying, you know what, I would love every other Friday to work from home.
Yeah, but the research doesn't seem to be really moving people's behavior.
No, and it's interesting. I was talking to, it might have been Trevor and Deb the first night here. From research to now, there's not many people in a large health system that are saying, where's the data? The big vendors that are selling products to healthcare system, they're selling access and service and marketing. So they want patients to use it. And I think for the types of things we're doing with general medical encounters, it's a video phone call. Yeah. So I think it's the validated tools that are required for rehab where research is really going to be paramount. But I really think we're on the tipping point for that taking off. So good point. Thank you.
Thank you.
Okay, thank you.